Hi. Today we'll talk about sedation again. Another episode for sedation in the ICU. Basically, today we're going to concentrate on analgosedation, which is a term that I hate. The term that should not be used at all. And a term that was developed, although it's an oxymoron, to cover a wrong practice, a practice that is wrong. If you remember from the last episode, we talked about how we should compartmentalize our thinking about sedation in the ICU to pain, anxiety, and delirium. And we talked about the disaster that happened in cardiac anesthesia, where there was a high incidence of recall under anesthesia because of the lack of use of amnestics. And we concluded that cardiac patients who had recall had no pain. But nonetheless, it's terrifying to feel that your sternum is being opened and you can't say anything and you're paralyzed. That will get us to analgosedation. So let's talk a little bit about the characteristics of sedatives. There are we all know the half-lives of sedatives, but we also know that sedatives have duration of actions that are much shorter than the half-lives. For example, the half-life of Versed is 8 hours, whereas the duration of action is 30 minutes. The half-life of Propofol is 6 hours, but the duration of action is 10 minutes. And that's easily understood because the termination of action for these sedatives happen because of redistribution, not because of metabolism. So the half-life is the amount of time it takes for the concentration of the medicine decrease to half in the blood, and that obviously depends on elimination and excretion and metabolism. But that has little to do with the redistribution. So, for example, propofol, when propofol is injected, the onset of action is 30 seconds. And that is called arm-to-brain circulation. The reason it's called arm-to-brain circulation is because that is a result of just the transport of propofol to the brain. So what they're trying to tell us is that propofol doesn't take time to put the neurons to sleep. It takes time to be transported. Once the propofol shows up in the brain after a bolus loading dose, the brain will shut down. The neurons will go to isoelectric activity for a brief period of time. Why is that? Because medications which work in the brain have to be lipophilic, obviously. And when medications are injected in the blood, they go where the blood goes. So they go to blood-rich organs. What are the richest 4 organs in the body for blood supply? They are the brain, the heart, the kidneys, and the liver. The brain also possesses another characteristic, which is it is the highest lipid content out of those 4 organs. So that's why the whole dose of propofol, which is supposed to be dependent on the weight of the patient, the whole of that dose appear in the brain immediately within like 30 seconds of injection. And that's an overdose. And the brain cells will just go to sleep immediately. But that also means that when you have a high concentration in the brain like this, and you stop giving the propofol because you only give one bolus, there's a huge concentration gradient. So this concentration gradient will result in propofol seeping out of the brain to the blood in 10 minutes, and the patient will wake up in 10 minutes. Doesn't matter if he has propofol swimming in his blood, because that's not in the brain. So the patient could be completely awake with the propofol in his blood. So having said that, we have half-lives of the medication. We have duration of actions of the medications. But the drug companies are not required by the FDA, for example, to report half-lives or duration of actions of medications after infusions, which is different. When you start infusing, the example that I mentioned before, which is that the propofol will come out of the brain fast because there's a concentration gradient, that example doesn't apply anymore because there's continuous infusion of propofol into the blood. So the concentration gradient from between the brain and the blood is not that high, and that results in retardation of the propofol coming out of the brain, and the duration of action prolongs. And that depends on a lot of things, including the excretion and metabolism. We don't have any idea. We have no data regarding the half-lives or the duration of actions of medications after infusion. Thankfully, we have one study that is called context-sensitive half-life. That study is a computer model. It's not even on patients, so it's not a great study, but that's the only thing we have. And with the computer model, they're trying to predict how long is the half-life or the duration of action of medications after infusion. What we know is that at 3 days of infusion, around 3 days of infusion, most medications start to have equilibrium between the three compartments: the brain and the blood and the fat. So that is mirrored in that study. We found that Versed accumulates so much after 3 days, and the half-life increases a lot, probably becomes almost a day after 10 days of infusion. Ativan was worse than Versed. Fentanyl was the worst that was studied, that we know, that we use. Alfentanil, which is a cousin of fentanyl with 1/5 of the potency, was worse than fentanyl accumulation. And propofol was okay, and the best drug that was studied was remifentanil. There was almost no accumulation for remifentanil. That's the shortest acting medication that works on the brain. So given that context-sensitive half-life, we now know that fentanyl accumulates more than Versed. Also, we know that the volume of distribution of fentanyl is huge, is actually more than the amount of fluid or the amount of tissue in the human body. So if you have a 70-kilo man, the volume distribution of fentanyl is 200 liters. It's actually more than the person. How is that? Because when you give fentanyl, it fills everything. It fills every single cell in your body. The hair, the eyes, the skin, the nails, everything has fentanyl in it. And then it comes out of the skin too. So you're exuding fentanyl around you, which makes fentanyl a great medication for a bolus, because you give it and you know that the patient is going to wake up quickly. But also it makes it extremely difficult to remove out of the tissues if you infuse continuously for a long period of time, because it will saturate all of those sites Yes, it will come out from the skin, but if you reach the point that you saturated all the sites, it's going to be impossible to get rid of this. Every time you metabolize some fentanyl, more fentanyl come from the fat and the skin and the nails and everywhere. You're never going to wake up. So we have to be careful with fentanyl infusions because of that. Also, fentanyl infusions cause what? Cause ileus and cause non-tolerance for tube feeds and addiction and many of these side effects that we know. So what happened with the analgosedation? What is analgosedation? Analgosedation is basically using fentanyl drips as the base sedative in the ICU, which is an oxymoron, but we'll talk about it. And that is the sedative for the ICU. And then on top of that, using bolus Versed or bolus Ativan. But the main sedative is fentanyl. How did that happen? How did we reach to this calamity? We reached to that, it was like the perfect storm. About 10 years ago or so, studies came out talking about that we underdose fentanyl or underdose narcotics, opioids, for patients who are intubated. And that was our fault. We used mainly Ativan drips or Versed drips. There was no fentanyl ordered for those patients, especially medical patients who don't have, I'm not talking about surgical patients, they have to get fentanyl drips because they're in pain, but somebody who's not in pain, just intubated for pneumonia, for example, these patients would get just Versed, just benzos infusion. They don't get fentanyl infusions. And what resulted from that, we discovered, or people discovered, using the BIS monitor, for example. BIS monitor is a bispectral analysis monitor that measures the processed EEG of the frontal lobe. That monitor can tell you how much sedation do you have and how much analgesia do you have. So they found that patients who are agitated, most of them had adequate sedation based on the BIS monitor, and most of them had inadequate pain relief. That means they were having some discomfort amounting to pain that needed some fentanyl, but we were not giving them. So that's the first storm. The second storm happened when nosocomial issues became forefront. Every hospital now is worried about nosocomial issues and reimbursements and public knowledge of that and all of these things. So nosocomial delirium is an important thing. So that's why people said, we are worried about using Versed drips and Ativan drips. And then on top of all of that, the icing on the cake, the third storm, which made it a perfect storm, people were about in 2006 and then 2009. 2006, a study was published showing that when you take rats and just sedate them, no paralysis, and put them on a vent for 48 hours, these rats had necrosis of some of the diaphragmatic myofibrils, which sparked a huge amount of studies that talk about movements in the ICU and keeping patients awake and walking around with an endotracheal tube and all of these things because of the fact that we were overdoing the sedation. And that's true, we were overdoing the sedation at that time. These studies came out, and of course if you want to walk patients in the ICU, you're going to have to do very minimal sedation. So hence it came the bolus sedation and the notions of keeping them awake. The bolus sedation came out and it failed immediately, practically in most ICUs. The nurses said, we're not playing this game. The patient is awake, he's gonna pull his endotracheal tube, I don't have time to run to the Omnicell to give him fentanyl, and it's not fair or Versed, and it's not fair for the patient himself or herself. Imagine if you go to the dentist and the dentist says, We mess it up all the time, so we're not going to give you lidocaine because lidocaine retards the healing or something. So I'm not going to give you lidocaine. I'm going to extract the tooth without lidocaine. I don't know what you're going to do to that dentist, but that's in essence what we suggested to do for ICU patients. We said, don't sedate them because we mess up the sedation all the time. We're not able to wake them up. So because of our idiosyncrasies and fallacies, we decided to torture the patients basically. But that failed. So when it failed, people said, okay, well, we need a sedation. We need a drip sedation. So some people, sane people, said, okay, we'll use propofol. And that was good because it's short acting and doesn't accumulate and all this. And some people thought that propofol is too good to be true, or the patient is hypotensive, is not going to tolerate propofol, so they wanted to use another drip. And the decision was made to use fentanyl drip because of the 3 storms we talked about. One storm talking about we are underusing fentanyl, another storm talking about nosocomial delirium, and another storm talking about bolus sedation. And when bolus sedation failed, people said, okay, so what drip should we use in a hypotensive patient, for example? Then they chose the fentanyl drip. That is the worst thing that happened in the ICU. It's as bad as using sufentanil only for sedation in cardiac patients. It's just not fair for the patients. And they recall everything that happened in the ICU, or most of the things that happened in the ICU, which shouldn't be. I don't want to recall my ICU stay if I'm an ICU patient. And in order to give it a little bit of legitimacy, somebody came up with the name analgosedation, which is an oxymoron. There's nothing called analgosedation. It's either analgesic or a sedative. It's either analgesic or amnestic. So fentanyl didn't change over time to become a full anesthetic. It's still an analgesic, but we are using it for hypnosis, like the cardiac anesthesiologist did. And when the patient is not doing anything and closing his eyes, we think that we did the right thing. But what we're doing, we're accumulating fentanyl. We're not tolerating the tube feeds. We're making it very difficult to wake up, and accumulating even more than Versed. So be careful of the term analgosedation. Thank you.